Hello, am I audible? Good morning to all of you. Today I am going to present CGR on allergy. It is a very common term which is commonly used in a clinical practice. Even into the general common language, people use allergy. I have allergy to this person, I have allergy to this person. So today I will discuss the allergy in the concept of myths and what is the fact, current evidence about the allergy. So my objective is to try to make understandable about what is allergy, what is the clinical spectrum of allergy, what is the allergy testings and why and when it is required, what is the preventive aspect of the allergy, and then I will share some AIIMS Jodhpur experience about the allergy at our center. So allergy is the immune mediated conditions, and it is a chronic conditions which having the wide clinical spectrum, leading from the benign conditions to the very life-threatening condition like the anaphylaxis. In the last 3 and 4 decades, worldwide it has been seen that the prevalence of allergy has risen dramatically, not only in developed country as well as in developing country also. If you see the data worldwide, there are 40 to 50% allergic sensitization to one or more allergens. If you talk about the India, about 20 to 30% of the populations have at least one allergy from allergy. And if you see here, almost all part of the India having the allergy spectrums. Some of the coastal area have very high prevalence, but most of the part having the allergy disorder. And the most important, the allergy disorder may coexist. A child or a person may have the asthma and allergic rhinitis or atopic dermatitis together. And the most important that it has a very serious impact on the quality of life as well as the economic burden. So I'm coming on to the myths. What is the myths? So hypersensitivity, allergy or atopy all are same and often used interchangeably. So let us understand the terminology. So hypersensitivity is actually objectively reproducible symptom or sign initiated by an exposure to defined stimulus at dose tolerated by the other persons. And it is a 4 type of reactions. The type 1 to type 4. Type 1 is actually IgE mediated reaction which is very fast, come in a minute to hour. Second is the IgM and IgG mediated hypersensitivity reaction. Third is the immune complex based hypersensitivity reaction. And fourth is a delayed type of hypersensitivity reaction, which is the cellular based. So allergy is basically this first one, this is the IgA mediated reaction is actually, hypersensitivity reaction is actually allergy. And to the ordinary harmless substance, which may not cause harm to the other subject, but some people may develop hypersensitivity reaction. And term atopy is actually allergy, which having the personal and familial tendency to occur hypersensitivity reaction which is IgE mediated. Now to understand whether the hypersensitivity and allergy and atopy are same, I have just prepared this picture. So hypersensitivity is a broad term containing both type 1 to type 4 reactions. Allergy is only the type 1 hypersensitivity reactions, and atopy is the type of allergy in which there is a familial as well as personal tendency for allergy. Now moving to the pathophysiology of allergy. So it is a complex interaction of genetics, environment, and socio-economic factor. In environmental factor, air pollution, infection, especially the viral infection to the rhinovirus and RSV infections, tobacco smoke exposure, pesticide, diet, especially the processed food, lack of fruit and vegetable are prone to the allergy symptoms or allergy development of allergy. Genetics, it has been seen that in family history, especially one parent is allergic, then there is chances of 20 to 30% their sibling have allergy. And if the 2 parents are allergic, then chances of 50 to 60% that their sibling may be allergic. And it has been seen that stress, the mental strain, both in the parent as well as children, may cause the development of allergy. Here I want to draw some attention on the basics of pathophysiology of allergy. So normally we have both innate and adaptive immunity which prevent from the daily exposure to the virus, allergens and pollutant. Whenever there is a break into the innate immunity, that is the structural barrier of epithelium, either into the respiratory epithelium or the skin or the gastrointestinal symptom, it lead to the entry of the allergens or the antigen into the tissue. But there is another set of immunity in tissue, that is the dendritic cells or the antigen presenting cell. They engulf the antigen and then present to the naive Th cell, that is the T helper cells. Depending upon the nature of antigens, it depends either stimulate the Th naive cell to Th1, which is protective, and Th2 response, which is allergenics. And Th2, once Th2 cell get activated, it produces a cascade of cytokines which lead to further allergic reactions, like the IL-9, which produce and activate the mast cells, IL-4 and 13, which activate the B cell, which further activate plasma cell, and then it switches from IgG to IgE productions. IL-5, which produce and activate eosinophil. And once IgE is formed, it get bind to the mast cell and basophils. And but these conditions is not cause allergy. This is just allergic sensitizations. Whenever there is a further exposure of allergens, it cause allergen bind to this IgE, which is bind to the mast cells, and it causes certain reaction into the mast cell and basophils, which lead to the immediate reaction due to the degranulation of some preformed substances to the mast cell, like the histamine, prostaglandin. And another response, that is a late response, that is due to the cellular response. So this is allergy. Whenever there is a allergic sensitization along with the symptom, then it is an allergy. Now coming to the second myth, allergy is a disease of affluent society only. So for understanding this myth, I draw your attention on some important concept, that is the hygiene hypothesis. Our environment contains plenty of germs, and this exposes our immune system, especially the infant, to develop protective immunity, that is the Th1 response. But whenever we live in a very clean environment, this lack the exposure to the many germs, and this may lead to the development of immune system toward the Th2 response. Another concept which is very emerging, the role of microbiome in the development of allergy. Our body consists of lot of microbiome in skin, nasopharyngeal cavity, lungs, GI system. Whenever there is an infection in a childhood, hygiene and nutritional changes, they lead to the microbiological change into our body, which is known as microbiota dysbiosis. And it also has some byproduct and metabolites which further have a capacity to influence our immune system. And it has shown that the infection and hygiene both lead to the more bias toward the inflammations, which may lead to the disbalance may go toward the inflammations rather than protective tolerance. And this may lead to the development of allergic disorder. So coming to our myth, allergy is a disease of affluent society. Though hygiene hypothesis say, according to the hypothesis, it look like it is more in affluent society. But if you see the risk factor, there are various risk factors for the allergy, and they work together for the development of allergy. It starts from the antenatal period, that is lack of nutrition like the vitamin D, sunlight, during the birth, cesarean sections, and after the birth, that is the breastfeeding, the introduction of the cow formula, then the introduction of some food particles like the peanuts, eggs, exposure to antibiotic, acetaminophen, they all lead to the allergy formations. On the other hand, exposure to pets and farms have been shown that they are protective from the allergy. And it has been also then the family which have large number of family size having the least number of allergy productions. So they together, allergy is not only disease of affluent society. There are many risk factors. So anybody can develop allergy. Now the myth 3, allergy is a disease of childhood only. And to understand this concept, I want to draw one very important concept of atopic march. By this figure, I want to show you that this is the age. On x-axis there is age in year, on y-axis there is a prevalence. The various epidemiological studies have seen that during the infancy, during the first year of life, children usually develop atopic dermatitis and food allergy. Atopic dermatitis first, followed by the food allergy. And during the time, over 5 to 6 years, it remains peak and then gradually come down. In the first 3 years of life, the allergic rhinitis and asthma develop, and they gradually increase in the prevalence till adolescent and adult. And the further course of the allergic rhinitis and asthma depend upon the several factors. It may fall down, or it may persist, or maybe become plateau. So, though it is true that the allergy is more common during the childhood, but it can start at any age, even in adulthood. Now, moving to what are the allergens which can cause the allergy. So, allergen is basically a small proteinous substance which produces the IgE-mediated immune response. It can be aeroallergens, the allergens which can move through the air and which can go inside the body through the respiratory tract. They may be indoor, that is present in our home environment, or maybe outdoor, be present outside the home environment. In indoor environment, the most common allergens are horse dust mite, cockroach, fungus, alternaria, or aspergillus, and pets, cat, dog exposure. In outdoor, pollen is the most common allergens. If you see, indoor allergen cause usually the year-round symptom. However, the outdoor pollens usually cause seasonal pattern of the symptoms. Other type of allergens are food allergen, in which peanuts is much more common worldwide. And other are venom, especially the Hymenoptera venoms, drugs, and latex. They all can cause the allergic reactions. If you see the aeroallergens in India, they vary in a different season as well as in a different part of the India. So it is very important to know about what is the predominant aeroallergen in our country or our geographical area. And to attempt this, the people has developed the pollen calendar. So pollen calendar is basically distribution of a pollen in a given geographical area in a different season or every month of the year. So I tried to find any pollen calendar for Jodhpur, but I did not find, although the AccuWeather shows some pollen calendar, but it's not accurate. The pollen calendar is developed for the Jaipur, although there are different city in the India which have the pollen calendar. I find the pollen calendar for the Jaipur, which is well developed. We saw which month of the year have different type of pollens. Now, moving to the clinical spectrum of allergy. So it is a very wide spectrum of clinical presentations. The most common is the asthma. But in both childhood and adulthood, the allergy is most common cause of development of asthma as well as a trigger of asthma. Second most common is the allergic rhinitis. Then they may be associated with the conjunctivitis, the allergic conjunctivitis or vernal conjunctivitis. Another type of allergy which is common during the childhood is atopic dermatitis. Then the food allergy, which is again very common in the childhood, and the most common is the peanut and the cow milk allergy. Others are the egg and other soya. These are the other type of food which can develop allergy. Drug allergy, which is common, so maybe irrespective of the age, can develop any times. And this is the venom allergy from the Hymenoptera bee or the wasp allergy, which is also not very common, but we often see this type of allergy. And the most drastic, that is the very lethal, is the anaphylaxis, which is often seen irrespective of the subspecialties. So this is the very life-threatening presentation of allergy. Now, how to make a diagnosis of allergy? So the clinical history is the key. Especially we have to see the temporal association with the allergen exposure, periodicity and the symptoms, seasonal or perennial variations, family history and occupational history, these things. And then we have to show relevant physical examinations. Here you can see that I have taken example of a child which may have the allergic sign, which is the just infraorbital regions. The child may have the salute sign due to the allergic rhinitis, and due to this, there may be development of allergic crease. So these are some salient features which give some indication toward the persistent allergics in the child. And knowledge about the local environment, especially the pollen calendar, is very helpful both in the making diagnosis as well in the management of the allergy. Now, coming to the fourth myth is that elevated total IgE level confirm the diagnosis of allergy. But the fact is that total IgE is the very most missed investigations in our societies. It is neither specific nor sensitive for making diagnosis of allergy. Raised level may be present in many childhood and adult conditions, especially in our country due to the parasitic infestations. Other conditions like the immunodeficiency, especially the hyper IgE syndrome, Epstein barbarus infection, they may cause the elevated total IgE level. So the bottom line is that total IgE should not be used for the diagnosis of allergy. Now moving to myth 5. Allergy can be diagnosed with a blood test, allergen, that is the allergen specific IgE. And this myth is further aggravated at a very large advertisement in the paper. We often see in every 2 or 3 months, or maybe very often, the blood test. Do the blood test, just 1 ml or 2 ml can do the 300 blood tests. And if you see the Times of India, you will see in the corner daily, they have given the ad for this the allergy. You give the 3 ml blood, we will test for the 300 allergens. This is coming into the Times of India almost daily. So to understand this, let's see what are the tests for the allergy. So there are basically two test for the testing for aeroallergens. That is the allergic skin test, which is the vivo test, and the allergen specific IgE, which is the vitro test, that is in the lab test. If you talk about the allergic skin test, it is an immunological test in which on the volar surface of the forearm or on the back of a patient, we put some very small quantity of allergen, maybe 1 to 3 microliter, and then they slightly pricking of the skins. So then the reaction is read after the 10 to 15 minutes. If the reaction is more than 3 mm, then the test is considered positive. And this is from our child, so where with the allergic test is done, we have to put a 1-9. We put positive and negative control. Then on the basis of history, we put the relevant allergens on the forearm, then the skin prick. It can be done by the percutaneous or by the intradermal route, but the skin prick test is most commonly used worldwide. Intradermal is more specific, but not good for the skinning test. But the point to remember is that this allergic skin test only indicate that some specific allergen are attached to the mast cells. It is not giving the diagnosis of allergy. So it is just indicating that this child or this patient is sensitized to this allergen. It is the clinical correlation which make the diagnosis of allergy. So this point should be remembered. Now coming to the second type of test, that is the allergen specific IgE. So it is produced against the specific individual allergens. And it is detected by the two methods, that is the ROST and the immunocamp. Immunocamp is widely used nowadays. But the pitfall is that it has a very high false positive rate, and due to the very non-specific binding site of the antigens. When you order, or you may wonder that you might have seen this type of report whenever the child or the parent come with this type of report, in which there are a lot of allergen may become positive. And then the patient may be confused, doctor also confused what to do with this report. So they give very high false positive rate to many of the food allergens, and then it is a very difficult to take a decision what to do. Sometimes the parents are so astute that they stop all this coming to the positive reactions. So this is a very big problems for the child, for the development also. If we compare the skin prick test to the specific IgE test, a skin prick test is a very sensitive, very specific, it is a cost effective, it is very excellently correlated with the allergens. So, but the point to remember is this: both type of tests do not give the diagnosis of allergy. This just indicate that this child, this patient is just sensitized to this allergen. It is the presence of the clinical correlation with the allergen which make a diagnosis of allergy. So coming on to our fifth myth, allergy can be diagnosed with the blood test. So we have seen that, say, a specific IgE level have a very high false positive rate, and so it could not be used as a test for the allergy. A skin prick test is test of choice to document the allergic sensitizations. So blood test is only done whenever there is a contraindication of doing the skin prick test, and then it may be reliable and may be indicated. Now coming to the myth 6, allergy testing should be done in all suspected cases of allergy. So it is also not true, because first, whenever you suspecting a case of allergy, patient having the suspected allergy, first take the detailed history and then assess whether the symptom is mild or moderate to severe. If it is a mild symptom, mild or intermittent symptom, then the symptomatic treatment. If there is an improvement, there is no need to do the allergic test. But if the symptom is moderate to severe or having the persistent symptom, then do the symptomatic therapy first, do the functional assessment like in asthma spirometry, do the structural assessment if there is some GI like the eosinophilic esophagitis, do the endoscopy. And if even though the symptom is not controlled with the pharmacotherapy, then there is a role of allergy testing. And whenever you're choosing to do the allergy testing, it is the skin test which is preferred over the blood test. So the fact is that it is not needed. Allergic testing is not needed in all cases. It should be individualized based on the symptoms. Now some newer or other investigations for the allergy testing. This is a component resolved diagnostic test, basophil activation test, and the allergen challenge test, which is important for the nasal and conjunctival allergy, as well as food allergy, because the food challenge test is the gold standard for the diagnosis of food allergy. Now, management of the allergic condition, so it is depend upon the underlying allergic presentations, and it should be done as per the national or international guideline, like the GINA guideline for the asthma, area guideline for the allergic rhinitis, and likewise. But in addition to the therapy or the treatment, the parent and the patient should be educated about the allergen causing symptom, which allergen causing the symptom in your child or in your patients, and how to limit this exposure, how to do the allergen avoidance. This is important in addition to the therapy. Now, coming to the 7th myth, allergic disease cannot be cured. And to understand this, again I am bringing back to the pathophysiology. We now understand that allergy is a T-cell mediated disease. And whatever the medication till now we have, they all act on the periphery. Either we have the antihistamine which act on a histamine, that is the chemicals, or having the biological like the omalizumab which act on the IgE, or having a mepolizumab which act on the IL-5. So they all act on the periphery. We don't have current drug which act on the T cells. So now the concept of the allergy immunotherapy, which actually work only disease modifying treatment available till now. The principle is that administration of increasing amount of antigen or allergen which can produce a tolerance. So this can cause the mast cell, decrease the mast cell degranulations. This cause development of more T and B cell regulatory cell. And this together lead to the development of Th2 immune response to the Th1 response. There are two types of allergic immunotherapy. That is, one is the SCIT and another one is the SLIT. There are systematic review and the meta-analysis in the favor of SCIT therapy, which may show some effectiveness in allergic rhinitis, asthma, and the venom allergy like the wasp allergy. However, they also show that there are a lot of side effects, local as well as the systemic side effect into it. So right now, the indication for the allergic immunotherapy is the moderate to severe rhinitis and asthma has frequent exacerbation despite optimizing your pharmacotherapy. However, the bottom line is that no, it has a very slow action, may take 1 to 3 years to show the visible actions. Has prolonged therapy and also costly. One session cost maybe take 2 to 3,000 and may have to give for the 3 years prolonged course. So coming back to our 7th myth that allergic disease cannot be cured, the fact is that there is increasing evidence that allergy may be cured with the allergic immunotherapy. However, the evidence is not very strong for right now. But some studies have shown in children with allergic rhinitis, if we give the allergic immunotherapy, it may prevent the development of asthma. Again, the data is not very robust, so we have to wait for that. But we can expect that in a coming future, we might have the drug which can cure the allergy. Now, what are the things which can prevent the allergic disorder? So, of course, the first and most is the healthy food and the basic lifestyles. It has been seen that the vegetable and the fresh fruit can prevent from the allergy. Allergen avoidance measures like the ensure sufficient ventilation in the living room, avoid damp pouncing conditions, wash pillow and soap twice, especially for the protection of the house dust mite, 3 to 4 monthly in a boiling water more than 50 degrees Celsius. Encasing the mattresses and pillow. Pet allergen. It has been seen that pet allergen, the basic avoidance measure in the removal of the pet. There is no other way to prevent from the pet allergens. Good sanitation to prevent from the cockroach allergy. Mold avoidance to control the indoor humidity to prevent from the dampness. Now, coming to the myth 8, which is very common and often parents ask about this. Does HEPA filter or vacuum cleaner is effective in reducing allergens? But the data is that high efficient particulate filter, that is the HEPA filter or vacuum cleaner, can make a little difference. But the data is showing that they do not cause the reduction in antigens, and there is no study which can show that the use of HEPA filter and vacuum cleaner have decreased on prevalence of allergy. In fact, some studies have shown that with the vacuum cleaner, there is a chances of more spread of that the house dust mite into the indoor environment and may lead to the further excursion of allergic reactions. So till now, there is no data that HEPA filter or vacuum cleaner is reducing the allergy trigger, so it is not recommended right now. Now coming to the anaphylaxis, which is the life-threatening presentation of allergy and which may occur in irrespective of the subspecialty. It is a very serious condition. Prevalence, although low, this is not very high. But the most common cause are either the food allergen peanut, which is very common in the West country, but fortunately there are very less chances of we are not reporting the food allergy in our country. medication and the venom allergy anaphylaxis. The mechanism is IgE mediated and clinical course it may be uniphagic or biphagic course. The clinical diagnosis is acute onset of the symptom, which is within a minute to hour of exposure, with involvement of the skin or the mucus involvement or both, or with the presence of one of the following, that is the respiratory compromise, maybe in the form of dyspnea, the breathing difficulty, wheezing, bronchospasm, hypoxemia, or it may be a stridor. Or maybe there is a cardiovascular involvement like the low BP or symptom of end organ dysfunction like the syncope. So investigation has no much role in the diagnosis of anaphylaxis till now, but nowadays there are development of biomarker like the tryptase, serum tryptase level, which when it is done within the 15 to 20 minute level, more than 20 unit of the tryptase level, blood tryptase level may indicate toward the anaphylaxis. And another one biomarker is the blood histamine level, which can be done in a 15 to 20 minutes. Once anaphylaxis is diagnosed, you should take care of the ABC, that is the airway, breathing and circulations. Adrenaline is the first investigation of the choice. It should be given into the 0.01 milligram per kg body weight, maximum dose is 0.5 milligram. Dose and the route should be intramuscular. Antihistamine steroids are very widely used in the anaphylaxis, but the evidence in effective in the anaphylaxis is not robust. So it should not be the first line of therapy. It should be, you can use as the ancillary treatment, but it should not be the first line of treatment. Regarding the prevention, we should know identify the trigger which causes the anaphylaxis and measure to avoid the allergens. Self-injectable adrenaline in West, it is very common to prescribe EpiPen, but our country is poor. We have some patients where we recommend the adrenaline in a 1 ml syringe and put into the spectacle box for the emergency use. Venom immunotherapy and desensitization from the allergy. Now I am coming to the last part of the presentation, the AIIMS Jodhpur experience. So we are doing the allergic skin test since 2019. We have this kit which have 37 allergens, including the aero allergens, food and animal allergens. And we have given one thesis to our PG student, which is the topic was allergic sensitizer in asthmatic children coming to our hospital. However, due to the COVID, we did not reach our expected sample size, but whatever I have done in 85 children, we found that allergic sensitization is a very common. It was present in about 74% of the children. And the most common allergen was the horse dust mite allergy, followed by some fungal allergy, that is aspergillus. We also presented this study into the national as well as the international journals. Now, my future direction in doing the allergic services here is to strengthen the allergic service at AIIMS Jodhpur, to collaborate with the other department. We see that a child or a patient with allergy may coexist with the other allergy. If a child having or patient having asthma, he might having the allergic rhinitis, atopic dermatitis or other type of allergy. So need to collaborate with the other department. Try to develop the pollen calendar for the Jodhpur. For last 1 week I am talking to the different botanists, but none of them are ready to do the work on that pollen allergy. So we will get some botanists to work on that. To explore the feasibility of allergic immunotherapy in selected cases. And to get in-depth knowledge of allergy, I have enrolled into a very 1-year hybrid course, that is a diploma in allergy and asthma, which is the combined course of University of Colorado, USA and CMC Vellore. So it is a 1-year course from the CMC Vellore, which had 4 contact sessions. So currently I am enrolled into this session, 2023 sessions. So key message is that allergic disease is a very common, and its prevalence is increasing both in development and developing country. It is true that it is more common in children, but it can occur at any age. Many allergies coexist in the same persons, so need to collaborate. Detailed history is the key for the diagnosis of allergic disease. Allergy testing is not needed in all cases, only needed in some selected cases, moderate to severe cases, or whenever required, the skin prick test is the prefer over the other, that is a blood test. And you know, now immunocamp is a very high false positive rate, so please avoid it. Allergic immunotherapy appear promising, can alter the immune response and can cure the therapy, but we required more robust data to act on it. Thank you. This is the end of my presentations. I'm happy to answer any query, questions. And after that, I will present, as per the ED recommendation, I will present the data, the research output from the Department of Pediatrics. If any questions, query, I will happy to answer.
नहीं काम कर रहा है. Okay, it's working. Okay. So in our OPD, we see a lot of cases of atopic dermatitis, and around 40% patient come with the IgE based test. They cost around 3 to 5,000. They are useless.
Yes.
Useless and even harmful also.
Yes.
Because the patient on his own avoid that particular food.
Yes.
So that kid become nutritional deficient. So we should organize a patient education.
Yes.
Patient education type of presentation that can be very helpful. And I want to know what the cost of that SPT test.
So very true, Dr. Adil.
How many patients can be?
Yes, very true, Dr. Anil. So yes, and why this CGR is that we want to bring awareness when to suspect, what is the actual allergy testings, and when should be done. The cost of allergic skin prick test is very, very low. Right now, we do not costing to the patients because for the 37 allergy, because just all the kit contains just 97,000 rupees. And if you allergen are different, if you take the Indian extract, which is not well standardized, it costs only 200 to 300 for 2 ml. And 1 2 ml bottle can be done in a 200 patient. But we have the standardized allergens, which is a little bit exported, and it is costly. One allergens take cost of the 2,000 to 3,000, but it is a well standardized and recommended also. And for the regarding testing, you can send in our OPDs, pediatric, you can contact any of the pediatric pulmonology teams. They can be done in afternoon any times. But remember, it is not recommended in atopic dermatitis because the skin condition is not good and it is not going to help into the atopic dermatitis. So it is not helpful in atopic dermatitis. But provided if the child or patient having the atopic dermatitis, along with that having the asthma and the allergic rhinitis, then it might be useful to do the skin. Yeah, so why I start? Okay. I have shown in the initial presentation the concept of atopic march. So during the first year, the child developed the atopic dermatitis followed by the food allergy. In the first year, during the infancy itself. Then by the 3 year of age, he developed allergic rhinitis and asthma. The atopic dermatitis and food allergy, the prevalence is usually low down by the age of 6 to 7 years, although it may persist or may develop into the adulthood. The prevalence of the allergic rhinitis and asthma actually go up even in adolescent and adult. And the further course is determined by the many factors. So it may persist, it may fail down, or it may be completely spontaneous in improvement. So you're right, atopic march. So why I have initially presented the concept of atopic march. So it is allergy is not a disease of only childhood. It can occur at any age.
Very nicely presented, sir. The food allergy actually is a very prevalent complaint by the patients and the parents. Mm-hmm. But in your experience, when you suspected true food allergy and anything you have done to prove that by food challenge test in your department, sir?
Yes. So I am not an expert of the food allergy, but the food allergy, we need to understand that food allergy have two parts. One is the food intolerance and food allergy. First of all, we have to differentiate between the food intolerance and food allergy. Many times we eat something and then have the stomach pain or something, loose motion, and be labeled falsely as a food allergy. It is not that. So food allergy is basically IgE mediated that is reaction. It may present with the skin and mucosal involvement. This is the very characteristics. Although it is taking through the GI system, but due to the sensitization, it may present with the mucosal and the skin involvement first, and then may hide the GI system. The gold standard test is the double challenge food allergen test. So I am developing phase. I have not done, till now we have not done any food challenge test, but definitely we are in a process to do that.
In urticaria, sometimes when patient complain, we try to contact with the dietitians and try to do food elimination on only carbohydrate diet for 1 or 2 weeks.
Yeah, that is a very... That is a very
basic,
important.
Very basic, yeah.
That is the important concept. Why in the beginning I told allergen is basically protein molecules.
Yes, sir.
But whenever you do the immunocap, it actually pick up the carbohydrate allergens,
yes, that is true.
which is actually not allergens. This gives the false positive repel. And so why the immunocap, which is just you are coming the ad daily on the Times of India, yes, 3 ml blood, do the 300 test, which is not required.
Yes,
whenever you require the blood test, take the history, take the important allergens and do only individual blood test or the skin prick test.
Rightly said. Thank you.
So because it gives very false positive result about the. Thank you. If there is no any further questions, okay, please.
Very nice presentation, sir. Regarding the evolved form of treatment, like when we change the cellular response from TH2 to TH1. So how effective it is that, as you highlighted in your slide, it take many years, even months to years, to change the cellular response of allergy. And as you might go through to the literature, because this is a very, very important, not in the sense of allergy, but it is very important for the all type of autoimmune disease. Because here the basics things diverse for all type of even autoimmune disease and allergic disease. So what do you think, what if you go through the literature, what do you think this is, how effective it is to change the cellular response? And any way or drugs, or what are the ways they are doing it? Just for the curiosity I'm asking them.
Okay, this is a very good question actually, very fond of it also. So we need to the basic principle of that. Just understand, when we take the food, same food from the mouth, in a large dose it do not cause allergy, but in go through the skin and a lung it cause allergy. So taking behind this principle, the principle of allergic immunotherapy is that whenever you give the allergen in very high dose, gradually increasing amount of dose, it will develop some regulatory self. It develops switching of the B cell from IgE production to IgG4 type of production, which actually change the tilt, the response from the inflammation toward the Th1 response. If you're asking about the evidence, there are systematic review and meta-analysis. We saw that the allergic immunotherapy work in asthma, allergic rhinitis, and venom immunotherapy. But if you go through the large guideline, like the GINA guideline for the asthma, they told that although the allergic immunotherapy is effective, but for by now we don't have robust data, because at the same time may cause the anaphylaxis reaction, some systemic and local reaction. So we need more data before advising for the, or before the just advertising for the allergic immunotherapy. We need more data, more work on that. And it also showed that because allergic disease, if you give during the childhood period, when the child do not have allergic symptom, actually they just have allergic sensitization. There is a cohort study from the Australia in which they did enroll the birth cohort study. They do the allergic sensitizations. And after the 4 years, they saw that the child who has allergic sensitization, there is 1/3 chances of their development of allergy. And then when they introduce the allergic immunotherapy, there are less chances of developing the asthma. But there are very few studies, there are a lot of side effects, they are costly also, they take long course, because treatment visible response come in a 6 months to 1 year. They are very difficult, the allergens therapies which is working all over the India. The main problem in doing allergic immunotherapy is the time and the compliance to the therapy. Because if you give some medication to any patient, they won't respond. If they not respond in 1 week, 2 weeks, 3 weeks, or 1 month, they will not come to you. So because it takes very long time, so it is not very much favorite. But it works, but we need more data.
Well said. So it is the scientific things which you are telling. I will tell you my experience and perception of this. As you rightly told that basically outdoor pollens, they cause the allergy. And I know that in my adulthood, almost a year, 4 to 5 times I used to get allergic rhinitis with sinusitis. And then when I joined the army, I started doing the exercise.
Yes, sir.
And when I do the exercise throughout the year, it has almost disappeared. Because I go outside, I expose to the pollens, which I don't know which I am sensitized.
Yes,
but I'm getting exposed to the pollen every day, taking the deep breaths and everything. And everything has disappeared. So probably I have developed the tolerance to those pollens. So that says that indirect evidence that regular exposure to the high dose of the pollens may change the immunological response, and you feel better about that.
Yes, sir. There's a lot of study on this point, and this is what basically allergic immunotherapy is doing, giving the gradual exposure in a large dose, in a scientific manner. But it is true, it may happen, certain child or the parent, adult patient also having the allergy, and over time, even with the same exposure, they do not have the same allergy. And same is true for the peanut allergy. Many of the child in a Western country have the peanut allergy. And over time, with the gradual exposure to the peanut, they actually disappear. So it is true, sir, you're right. So now moving to this is the latest additions in the CGR, which at the recommendation of the ED, so you have to present the scientific or the research output of your departments. So it is my privilege to presenting our research output or the research activity of our department. So we have the many subspecialty over times under the guidance of Dr. Kuldeep Singh. The many subspecialty have been developed. The name are the genetics, medical genetic, pediatric intensive care, pediatric nephrology, pediatric hematology and oncology, pediatric pulmonology, pediatric endocrinology, pediatric emergency, and pediatric neurology. And the many are in the pipeline, like the pediatric gastroenterology, pediatric immunology, pediatric cardiology, and pediatric orthopedics. If we talk about the research, the genetics have the many research extramural projects. They have 4 extramural projects under the NIDAN, Genome India, and the NHM. And the main area of the focus of the genetic is the antenatal screening, micronutrient, effect of micronutrient on the genetics expression, anthropometry, and diagnostic test. The second is the pediatric pulmonology, which is our interest, and we are working on the cystic fibrosis, asthma, allergy, and pediatric sleep, as well as the vitamin D deficiency and the relation with the allergy. Pediatric ACU have the many extramural and intramural projects, and the area of interest, the theme of interest is the fluid therapy, sepsis, antibiotic stewardship program, pneumonia, nutrition, as others, etc. Pediatric endocrinology have 5 extramural projects, and their area of interest is diabetic mellitus in children and the growth, and also telemedicine and obesity. Pediatric cardiology actually don't have our subspecialty, but there are very long project, that is the congenital rubella surveillance project is going on, which actually look for any congenital defect in the heart in the first year of life. In a pediatric nephrology, there are 3 extramural projects and 7 intramural projects, and the area of interest is the mainly nephrotic syndrome, that is the CKD, and COVID effect on the nephrotic, that is the renal symptoms, renal tubular acidosis, and ABPM monitorings. Pediatric emergency has 2 extramural projects, and the area of interest is the dengue and simulus trainings and sepsis. Pediatric hematology had 1 extramural and 4 intramural projects, and the area of interest is the hemoglobinopathies, hematological malignancy, and nutrition and anemia. Pediatric neurology had 4 extramural projects and 2 intramural projects, and the area of interest is the rehabilitations and waste syndrome, AI, and the neurological complication of the COVID. Regarding the student research, total 46 MD theses, either they have completed or in a process. We have 23 fellow, in which about 1/3 of they have passed and joined another college. Some of them have also did the DM also. DM desertions, we have currently 5 DM students, and they are doing the DM right now. So now at this point, I invite a student to participate in the ongoing research in department. And for the further information about the department research, I invite our head of department, Dr. Kuldeep sir, to further give us some elaborations on this project in the Department of Pediatrics. Thank you.
Good morning, and thank you, Dr. Prawin, for a very nice presentations. I think this is of more of interest for the interns, and because they are the senior most in the MBS program, they can also guide the undergraduate students. So with this presentation, with this outline of the research, we request the interns to either involve themselves in the ongoing research projects in the department, or they can ask the juniors also, because now we have a series program also, Student Initiative Research Innovations. And also there is a collaboration with the IIT Jodhpur, so there are many research opportunities available. And now just what, I may not be wrong in saying that the pediatrics department is the institution in itself, but we have a lot of projects which are through the collaboration of multiple departments. And I'm just going to highlight some of these. One is the Nidan Kendra, started in 2019, and we have the department ranging from the anatomy, biochemistry to radiology, obs and gynae, pediatrics, and other departments. And they have phase 1 is ongoing. Phase 2, which is going to be in the Sirohi, has also been approved. So there is a lot of opportunity for the other faculties and the students to join this project. We have also another important area, that is Health Technology Assessment Hub by ICMR DHR, Department of Health Research, which is a long-term project of 5 years. So this is a center, and you can do multiple research in this area. Similarly, we have a satellite tribal health research center at Abu Road with the Center of Excellence at AIIMS Jodhpur, which is funded by Ministry of Tribal Affairs. Now here there are multiple projects you can work on. Only thing is that you have to design a project, take the ethical permissions, and you can start the work. And coming to a very important, that is a NIHR funded Global Health Research Center, which is a virtual center for multiple long-term conditions. So this is for the, previously it was known as multiple morbidity, but it is now termed as multiple long-term conditions. So any person having some problem of a non-communicable disease can have multiple other problems, including the mental health issues. So this is a very prestigious project for AIIMS Jodhpur. There are 3 countries are involved: India, UK and Nepal. And the UK is the coordinating site along with the centers in Nepal and India. So Nepal has 1 center and India has 3 centers. That is a Public Health Foundation of India, Hriday Foundation and AIIMS Jodhpur. And for this project, the most important thing is that it will lead to awarding 4 master degrees, 3 PhDs and 4 postdoctoral fellowships, which will be partly completed in India and partly in UK. And this is through a competitive exam which will be conducted, and then they will be awarded. Apart from that, they are basically for developing the implementation research for non-communicable disease. So it can range from the endocrine disease, diabetes, hypertension, or a renal disorders, or it can be mental health problems, so and the cancer. Apart from that, there are multiple disabilities also occurs because of certain other conditions. They can also be used as a part of this. So ultimate aim of this project is to develop the competencies and the training for the younger faculties and the scientists in the area of implementation research, which is related to some testing of the and validation of the some of the policies. For example, the telemedicine, how the clinical decision support system can be used through the telemedicine, and how we can validate in a different populations throughout these 3 countries. So there is a lot of scopes for the younger people to join these courses, and those who are interested can contact the Department of Pediatrics and or me, or so that we can include. Already the multiple departments from AIIMS Jodhpur are already there: medicine, endocrinology, cardiology, nephrology, psychiatry, obs and gynae, and pediatrics. They are all involved, and the community medicine and family medicine, public health. So because these projects, they decrease the departmental, or they merge the departmental boundaries, and they are very important for the overall development of the goal. And because this year is the G20, that is the One Earth, One Family and One Future. And as a part of that, One Health is also important. So if we do the concerted effort and do the research in these directions, which are collaborating in nature, we have a more output and more healthy population of the country. So with this, I thank you all for listening patiently for the departmental CGR as well as this research. So this is a new initiative which has been suggested by our executive director, that at the end of the CGR, the department can present in 5 to 10 minutes about any project or any work which is going on, even it is a the PG research which is going on can be highlighted, so that everybody is aware in the institute that there are so many things are happening, and they can also stimulate to do further research in this direction. Thank you very much. Thank you.